dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of Wilms tumor or nephroblastoma associated with some teratoid features. So this is a case of a 4-year-old female patient who presented with an abdominal mass noted by the parents and who underwent upfront surgery. This is extremely important. The patient did not receive chemotherapy prior to the diagnosis. Rather, she underwent upfront surgery. And as you can see here from the low power magnification, we have a tumor that is a triphasic, meaning we have a blastema component, we have epithelial component, and we have the stromal component. On a slightly high power magnification, the blastema here is really clearly identified the small rounded blue cell tumor, and then we have tubule formation. Well-formed tubules are identified, and then we have the non-discrete stroma. Nothing really peculiar about the stroma. This is only non-specific type of stroma. Now, on high power magnification, we could identify some areas of necrosis, but remember, the patient has not received any form of chemotherapy prior to surgery, so this is considered to be like spontaneous necrosis. We have to comment on this in the report, but this is not a treatment related. One thing that we also should be looking for is the presence of anaplasia, in which we have enlarged hyperchromatic cells that are nuclei 3 times the size of an adjacent nucleus, in association with abnormal, in particular tripolar mitosis, none of which was present in this peculiar case. And again, here we have the blastema, and then we have rosette-like with formations of the epithelium with occluded lumina, but then we have areas showing the typical tubule differentiation or formation, and this is considered the evidence of the epithelial differentiation. As I've said, the stroma was non-discrete. There was no evidence of differentiation in the vast majority of the tumor. However, in one focus, I could identify immature cartilage present that is very much reminiscent to the immature cartilage that we sometimes encounter with immature teratomas in the ovaries, for example. And this is along with the presence of an epithelium, mucin-producing epithelium in another focus, are the features for which the previous diagnosis of teratoid Wilms tumor used to be rendered. Nowadays, as per the new WHO classification, we do not really assign this teratoid term to the Wilms tumor or nephroblastoma. We only say that the epithelium shows some evidence of heterologous differentiation in the form of a mucin-producing epithelium, and the stroma shows evidence of heterologous differentiation in the form of cartilaginous differentiation, not more than this. Now, one area that was very importantly examined and should always be examined in Wilms tumor in general is the sinus fat, which was negative for evidence of a tumor, but we also have to examine the sinus vessels, and this is a large-sized vessel vein in the sinus showing a tumor thrombus that is lined here by endothelium, and in here shows evidence of attachment to the wall of the vein. This is important actually to note. However, it's also important to specifically look at the excision margin of the vein, and in this particular case, although there was evidence of venous invasion, the margin was completely negative. And then we have also to look for evidence of nephroblastoma or nephrogenic risks that are identified, as in this case, at one around the tumor near the capsule of the kidney. So this is considered to be interlobular nephrogenic risks. Only small foci could be identified. Now, CDX2 was positive in the areas of the mucinous epithelium, unlike the tubules in the background, which were completely negative. And interestingly, GFAP was positive in the immature cartilage that I just showed you. I've noticed actually that GFAP is usually positive in the immature cartilage in immature teratoma as well, and thus can be used like a surrogate marker to help support the presence of the immature cartilage. Now, importantly, I always perform P53 because even in the absence of frank anaplasia, the presence of a mutant P53, unlike this case, this is not a mutant, this is the mosaic or wild type staining pattern. But if we encounter a mutant type P53, this would be consistent with a nuclear arrest, and this is important because it's frequently associated with anaplasia, unlike this case. So there was no evidence of anaplasia, neither focal nor diffuse, and there was no evidence of a nuclear arrest. Now remember, because the case was operated directly without a previous administration of chemotherapy, we have to evaluate the case as per the COG rather than the SIOP protocol. And because of the favorable histology and the absence of focal or diffuse anaplasia, the case is considered to be intermediate risk. Now, the way we evaluate with the SIOP is completely different. I'll be sharing some videos with you on how to evaluate Wilms tumor or nephroblastoma as per the SIOP protocol, because these patients would have received chemotherapy prior to surgery. So the final diagnosis in this case is a triphasic nephroblastoma, favorable histology because of the absence of any evidence of anaplasia, intermediate risk category as per the COG classification, and the local stage is 2 because of the presence of evidence of venous invasion in the absence of invasion at the margin of the tumor. Remember that sometimes with Wilms tumor, you can encounter some heterologous elements, including cartilage, rhabdomyoblastic differentiation, that are considered to be heterologous elements from the stroma, or mucinous epithelium that is considered to be heterologous elements from the epithelium, as they do not carry any prognostic significance. The term teratoid Wilms tumor was dropped from the most recent WHO classification. I hope you find this tip useful in your daily practice. Thank you.